Great, thanks everyone, and we can start the recording if we haven't already. My name is Olivia Alford. I'm the Associate Director for Delivery System Reform at the Office of Maine Care Services, and we are so excited to be here today with our team from the Transferring Maternal Health model to talk about this work that we're doing. We're gonna go through a lot of information today, draw attention to some highlights and hear from some of our partners in this work. But I think the biggest message I want everyone to take away from today is that this is a 10-year grant and we are in year one, and there's a lot of things that have already happening and a lot of things yet to come, and your attention to this work is really appreciated because you're gonna be a great partner with us in whatever aspect of this work you best fit in. Can we get the slides up too? Okay. And I'll just keep going into the main agenda for today on the next slide, is that you'll hear from both myself, Maggie Jansen, the Maternal and Infant Health Coordinator, to help you guide through this agenda today from Maine Care, but we're gonna cover just basics. What is this Transferring Maternal Health TMaH model that we're talking about today? What has already started, what's coming next, and really how to engage. We wanna make sure that the public is aware of the work that we're doing, and then also make sure you can find where you can fit in, whether it's in work that's already started or work that's yet to come. Next slide. What we're not going to talk about today is really in-depth funding numbers and discussions. Some of the work that we're going to talk about at the end is really not that well defined yet. Again, there are later years in this grant, so we're going to be honest that some of these things are still a little bit yet to be determined around what we're going to do with certain scopes of work. So you can provide feedback on that afterwards. And we're not going to talk about what's called the Rural Health Transformation Program, which is being handled through a different stakeholder engagement process. And if you don't know what that is, quickly go to the next slide. The Rural Health Transformation Program is an initiative by the federal government that's going to disperse $50 billion in funds to the different states for over a course of a 5-year period to support rural communities and rural health. This comes in part from the federal budget bill that passed this past summer, known as HR 1, where there were both significant cuts to eligibility in certain health insurance programs, as well as a number of other changes. But there was also this Rural Health Transformation Program fund that was put forward, and we are in the midst of developing Maine's application for this work. It's a very hot topic. Next slide. We have a whole different stakeholder engagement process for that work, where Maine is developing our rural health transformation plan. We have about 6 weeks remaining to develop this really ambitious plan that could bring anywhere from 100 million to several hundred millions of dollars to Maine over the next 5 years to support rural health. It's a statewide effort with the governor's office, Maine Care, other public health agencies, the department as a whole, and it involves collaboration with the public. Next slide. If you are looking to provide feedback on that process, again, we're not going to do that today. There's a public website and we're accepting public comments through October 1st, and there's a series of listening sessions and webinars, 2 of which just happened this week, to go over that broader scope. So we'll put the link to the webinar, to the public comment form and the website in the chat, but you have until October 1st, next slide, to submit public comments about your ideas for the Rural Health Transformation Program. So enough with that, we're going to go back to TMaH. Next slide. You can go again. So the Transferring Maternal Health work, back one, is coming at a really good time. It's both a time of really increasing need for investment in maternal health and all the work that surrounds it. It also comes at a time when Maine's done a lot of planning. Maine Care has expanded eligibility. Maine Care, as well as the provider community as a whole, has really invested in integrated care models, team-based care, training, innovations coming from all over, again, external to state government, internal to state government, Maine CDC, all sorts of partners have been working on this issue because it's an escalating need. Maine Care also has, again, speaking from a Maine Care person, has also invested heavily in Maine Care rate reform, which has been one of the pillars that really makes this a good time for the state to be approaching systematically how we look at maternal health. Next slide. At MaineCare, again, where this grant is situated within the department, we are both a payer of services, provider of health insurance coverage, but we also recognize that we have an important place to be a lever for policy change. So the TMaH funds are specifically for the Medicaid agency to help build out what is our role in being a lever for change, planning, capacity building, resources, and ultimately payment and coverage changes to support improved access and outcomes in maternal health for women on MaineCare. Next slide. The grant itself is a 10-year grant that is expected to draw down about $17 million in federal funds to invest in infrastructure, planning, and services, and again, includes longer-term sustainability through investment through MaineCare in different payment models, perinatal supports, and services that don't exist today. In addition, there are several other uses of funds that you'll see throughout the presentation. We started this work in January 2025, and it goes through December 2034. And there's 2 different time periods of the work, which we go to on the next slide. We have a 3-year, what they call a pre-implementation period, followed by a 7-year implementation period. The pre-implementation period helps us build skills and capacity to launch all aspects of the model, including the increased Medicaid covered services, including the value-based payment model. But there really is money going out the door even in year 1, and there's supports coming through different versions throughout the whole 10 years. And we can go to the next slide before I'll take a pause. TMaH focuses on 3 main areas: access to care, infrastructure, and workforce capacity, quality improvement and safety, and whole person care delivery. And if you go to the next slide, we'll see that there's 13 elements, as we call them, within TMaH that span such a wide range of topics. I'm going to pause on this slide and not go through each one of these because you're going to hear a lot about them today. But what's really important to think about is how all states that are participating in the Transforming Maternal Health work are doing activities 1 through 9 as it relates to their state structure. So we'll talk about how we're approaching each of those. When Maine tailored our application for this federal award, we added on the 4 items at the bottom as really important for Maine and what we wanted to get out of this work. So we will talk again in detail about some of these and less detail about others. We have so many expected partners or existing partners in this work that you'll see on the next slide. It's meant to be a little bit overwhelming, but it's also why we're all here today, is looking at all the work that's been done in the past and we want to do together. This is an opportunity to sort of bring it together and create some sustainability and structure around it as we move forward in Maine. So if you don't see your name here, it's not really intentional by any means. Please reach out to us. We'll add you to the slide for next go around. But it's just all meant to say that we are working together on this, and MaineCare is just one piece. But we see our role here at this juncture, at this point in time, as being very helpful to bring this all together. So the PowerPoint today, what we'll do is we're going to take pauses between different sections to allow for some comments or questions. So I'm going to take a pause now, and you can put comments or questions in the chat, or if you'd like to speak up, we could do that to see how it goes. And if you don't have questions, we can move on to start covering what work has already started. Any questions over the overview? All right, so feel free to put your questions in the chat throughout. I know I didn't give you that heads up initially, but I'll turn it over to Maggie Jansen, Maternal and Infant Health Coordinator for MaineCare, to walk us through what's already started.
Thank you, Olivia, very much. Okay, on to the next slide. So what work has already started? We are going to first highlight some great work that's begun around rural regional planning, which is one of those 4 main specific elements that we include in our application. And to walk you through what work we have started in this element, I'm going to hand it off to our TMaH Rural Regional Planning Liaison, Kelly Bowden. Kelly?
Great. Thanks, Maggie. Welcome, everyone. It's great to see. I see a number of familiar names on the list here. So it's great to see everyone and some new names as well, new to me names. Just a little bit about my background. I was born and raised in the Bangor area. I was actually born at a hospital that no longer exists. And the first 20 years of my life were spent in Bangor with day trips to the coast and MDI and Deer Isle and all those beautiful places. And then I moved to Portland to finish college. And I lived in the greater Portland area for about 30 years and moved to Western Maine about 8 years ago. So I'm living almost on the New Hampshire border. So I have lived in several regions of the state. I worked as a nurse and nurse practitioner in the newborn intensive care unit at Maine Med for about 20 years. And then for about another 20 years, I traveled the state providing education and consultation services to healthcare providers on a variety of topics related to pregnancy, childbirth, and newborn care. And when I retired, I worked for the Perinatal Quality Collaborative as a consultant and have been working on the state maternal, fetal, and infant mortality review panel. And I joined this work in May and really excited about it. So if you go to the next slide, Julia, that'd be great. I want to thank Julia Dudley, who's been behind the scenes today running the slides. Julia, do you want to just unmute quickly and say hi?
Yes, had to find my button. Yes, I'm Julia Dudley. I'm the Maternal Grants and Data Manager here with TMaH. Nice to see you all today.
Thanks. All right. So what are we talking about when we talk about rural regional planning? So we know all the regions of the state are quite different. We know that resources are becoming more scarce every day. And so really coordinating our resources will help us maximize what we do have. We know that workforce recruitment is an issue, and I think back to when I was working at Maine Med, and we would have people hired as certified nurse assistants, and they would go to nursing school and become RNs. And so that's just one example of how we can build our workforce. There's many other types that we could do similar things. And really the work in the communities is done best when it's driven by the community. You know your community far better than I do. And so really looking forward to working with you as we set priorities and strategies. Next slide. So part of the work and one of the little circles on that busy circle slide that Olivia showed was family voice. And we're very fortunate that Anna Sear at the Maine CDC has built some infrastructure around this. And there's the family partnership framework materials. We want community partners, we want health systems and families integrated in all aspects of this. So Anna's contact information is on this slide, and I'm going to ask Maggie to put in links. So if you are someone who's had a baby in the last year or so, you can go to this link and you can sign up to have some training and how best to work with communities and health systems. If you're in a health system, there's a link for how do you find a family in your region that would be able to participate in the meetings. Great. Thanks, Maggie. Next slide. So, what's happened so far? In early May, we hosted a webinar that was included the senior leadership at all of the hospitals. We invited a broad range of people, both hospital-based and community-based. And then we followed that up with an in-person meeting in June to start talking about this. We followed that up with virtual regional district meetings where we, and again, invited communities and community partners and hospital partners, anybody that was interested. We went over some of the data by community. I had Anna Sear present about the family work and how to engage there. And really just a discussion, an opportunity for the community, for the region to discuss what kinds of things are happening in their community and what they might want to work on. We've built a resource inventory that I'll show you in another slide or two. And then I've been hosting weekly office hours for people to ask questions. What's happening soon is there'll be a release for a request for applications. And this is to really provide funding to convene meetings in the different regions of the state. Multiple organizations can apply for the funding, but there will be only one award per eligible geographic area. Next slide. So as promised, this is the maternal resource inventory by region that we created and was initially populated by the public health district liaisons. This is a starting point. This work is going on for several years. So we are very open to feedback. We want people, we want to know who we're missing. We want corrected information. If we don't have people's names or contact information. We really are planning to be flexible as we learn, and we want to make sure that there's really broad and diverse inclusion as we move forward. I think at this point, I turn it back to Maggie. Is that right? I'm happy to take any questions people have. And is this where, do we want to pause here for that?
Yeah,
Yes.
let's go ahead and pause and we can open it up to questions either via the chat or you can unmute, raise your hand, and we can take questions that way. Jessica Duma says it would be great to add public health nursing to the inventory. And Kelly, I'll let you weigh in on that because I know that that is in there. Yeah.
Yes, in fact, Jessica, thank you. People have been adding that under community organizations and supports. We've got a great list of public health nurses so far and happy to keep adding to that. And Catherine, thank you for that question. Yes, is the short answer that Lewiston, Auburn, though it is a city, we know that you provide care to very rural regions, including the town where I live, that people drive distances. So Olivia, I saw you come off mute. Do you want to add to that?
Yeah, I think you'll see in the request for application the different geographic areas that are eligible for funding, and within those areas, it's really about focusing the planning on the rural communities in the area. So while I think technically, the focus shouldn't be on Lewiston, Auburn, city center, it would be within the parts of the county which that are rural, that again are receiving care throughout the county. So you'll see, hopefully we've tailored this well in the RFA to get to the point of what the funding is intended to support. It's not an enormous amount of funding going out per year. I mean, I'm hesitant to give a dollar just because it hasn't gone through all the approval processes, but 50, 60,000 is our goal. It depends on the number of regions that apply. It depends on what CMS determines is allowable funding. We are working with CMS on all of this, and all funds have to be approved and all the processes have to be approved. So it's a process. And I want to reiterate that this is the initial launch of rural regional planning through this RFA. We expect there to be several rounds of funding that go out. We expect to spend funds in different ways to support rural regional planning, which may mean that some groups or providers need a different type of resource to engage in this process, and we're open to that. working through those conversations with others. So you can appreciate probably the need to get some funding out and then to refine our approach and build on it in this 10-year period, because we intend to support this for several years.
Great. And I see people are adding in about Maine families and home visiting, absolutely including them in the community organizations. And we have a number of them already on our list. Family docs who do OB, absolutely. I think many people are including that under the FQHCs and physician practices. Right now, Hillary, we are still working on the inventory. So if you have questions, please do reach out. I'll put my email in the chat and happy to follow up with you at any time. And the same, Mona, if you want to email me, be happy to do that.
And I see Aura's question we can get to, because we have something coming up soon about midwives. So if you don't mind, Aura, we can get to that in just a few slides. So
Yes.
we'll hold off on answering that. And Jay?
And we do have, or we are collecting midwives. You'll see under the OB/GYN and midwives that is inclusive of all midwives in the state.
I think we're going to have to move on just for time's sake.
Yes.
They're definitely just in the chat. Like this is supposed to be an illustration of a spreadsheet that's a thing filled out in a long way. So we can provide a way to make sure your type of organization is reflected. Maybe just put Maggie's email or Kelly's in the chat.
Yep.
Also, when we do release the RFA, there will be a public webinar to explain the RFA, so we can more detailed questions about that and who's eligible to apply can all be part of that process, just to make sure we get through the rest of the content.
Great, thank you. We can go on to the next slide. So right now we're going to move on to a couple of the other elements, actually the first two that are mentioned in that big list of 13 elements. So the important thing to remember when we look at that big list of 13 TMaH elements is that each of those elements have several federally required deliverables attached to them that must be met by our team during this pre-implementation phase over these 2.5 years ahead of us. With some of these elements, the majority of those deliverables have already been met, like with this first one that you see here, increasing access to certified nurse midwives. Because prior to even us putting in the application to TMaH, Maine already has established parity in pay and a full practice scope for CNMs. We are one of very few states actually in the country who have that. So we were very much ahead of the game in that sense. And so we actually have already met 2 of the 3 federally required deliverables listed for this particular element. The one deliverable that we have not yet met and that we will be focusing on over the next 2.5 years is working on assessing and creating a billing pathway for interprofessional consultations between midwives and other providers, including maternal fetal medicine specialists as appropriate and needed. So that just kind of explains what our work will be going forward in that element. And then we get to the second element that's listed there, increasing access to licensed birth centers. And that is an element where Maine is definitely behind the starting line when it comes to meeting federally required deliverables for TMaH elements, because Maine is one of many states in the country that do not have licensed birth centers. We currently have 3 birth centers in the state who are doing work, but we do not have licensure in place. So we are working with CMS right now on establishing what our expectations will be around these deliverables. But in the meantime, we are engaging in activities that we believe complement the federal expectations. And those are the 2 that are listed here. Researching what other states' licensing and reimbursement practices are around birth centers, and also investing in perinatal transition improvements for planned out-of-hospital birth. And I'm going to now turn it over to our TMaH consultant, Morgan Miller, who will walk you through some of that work, which has already begun. Morgan?
Hi, ready for the next slide, I guess. I am Morgan Miller. I am a certified professional midwife, and it seems pretty on point that we just start out with describing what the differences and types of midwives we have available in Maine are. There are 3 primary types of midwives that are practicing in Maine right now: certified nurse midwives, certified professional midwives, and certified midwives. They are very, very similar, but have slight differences in educations and focuses of practice, and ultimately where they end up practicing in the community. The similarities amongst them all tend to be around taking care of pregnant people and birthing people, and people around gynecological care, reproductive care, and care of the newborn. There's slightly different pathways of education, and then slightly different pathways of getting national licensure, and then of course getting certified in the state as well. So hopefully that clarifies what a midwife is for everybody. We can do next slide. And just to clarify the other biggies of what actually is a birth center, as Maggie said, we do have birth centers in Maine, but currently we do not have a licensing process for them. So those 3 birth centers that are not affiliated with a hospital, they are freestanding, do match the national accreditation regulations for licensing for that standard from a nationwide perspective. However, the state of Maine doesn't currently have a process for them to follow through and get a state license. So we do have 3 that exist and are hopeful that we can increase access to getting more at some point, but that's kind of outside of this. Next slide. Perinatal Transitions is the program that I've been working with in the state that TMaH has been really wonderful in supporting. And our goal around it really is around improving the communication and pathways that happen across the state, regardless of what system you're working in. So this is very applicable to the rural experience. When people are working in community settings and working with a community-based provider, or for example, a midwife, they often are still engaging in the healthcare system with hospitals as well. There's kind of an adjunctive style of care that goes on with it. The Perinatal Transitions program exists to improve that communication between those systems and improve the experience of clients and patients that are receiving the care from these providers and systems. So the program exists to improve both the safety and efficiency of transfers of care from community births and into hospital settings. This really looks like gathering information, pooling from the community and providers and patients what's working and what isn't, and analyzing that in the context of how our birthing outcomes are going, and then setting up system-wide protocols so that we can all continue that improved standard. Through Perinatal Transitions, we've currently done 19 community birth practice trainings out of the 4 EMS regions engaged as well. This is very much so growing. So if you do not have this established in your facility, just hang tight. You're probably going to hear from us soon. We are also working on a way of having a systemized identification system for community providers when they are engaging in a hospital space, so that that clarification of their clinical role is established as well. Another one of our projects we're working on right now is updating the best practices transfer recommendations for community midwives when they engage with the hospital and when EMS is activated as well. Our next steps for the program are to really complete the rollout of this in facilities and with EMS, and continue to fine tune it amongst the community providers and midwives. We're going to finish this identification system, and then we are also looking into having a more expansive way of collecting some of this data to analyze. One of the program's goals for the next years as well is to offer integrated drill programs that will look like doing skills practice with community-based midwives and hospitals and EMS all at the same time to run a complete drill of a transfer of care. These are currently things that most of these systems drill on their own, but it is pretty rare to have that engaged with all three systems at the same time. Next slide. And then we're handing it off.
Yeah, thank you, Morgan.
Mm-hmm.
Would we want to stop now to answer any questions about Morgan's work? There's been some activity in the chat. Somebody was Christine Jenkins was asking where the three birth centers are. One is in Bangor, one is in Topsom, and one is in Bath. And wondering, I did put in the link to the perinatal transitions program if anyone wants to check that out. And Morgan can also put her email in the chat as well if anyone would like to connect with her offline from the meeting today to ask questions. So, great. Harriet says, I don't see any pediatric support for out-of-hospital births. Okay, that's good to know. And we should we'll follow up more on that, Harriet.
So that definitely is a part of the perinatal transitions program. And I'm sorry it didn't get listed on these slides, but it's very much integrated as far as setting up these programs. It's a great point.
Good. Thank you for bringing that up, Harriet. All right, well, I will move on to our next element, which is covering doula services under Maine Care. This is an integral piece of our pre-implementation phase. We are definitely underway with this work. We have hired two wonderful doula consultants, implementation consultants, Sarah Toohey and Kate Vaughn, who are on the call today, who will walk us through the work that they have been engaged in so far. And it will include, this work will be including these 3 bullet points that you see here: establishing a statewide doula support council, developing policy and reimbursement for doula services under Maine Care, and then supporting doula service implementation through a state plan amendment. And I will now pass the baton to Sarah or Kate. I'm not sure. It'll be a surprise.
Maggie. We're going to introduce ourselves first, and then Sarah will begin to take us through the slides. Hi, everyone. My name is Kate Vaughn. I am a doula based in Southern Maine in Portland. I am one of 3 co-directors at the Maine Doula Coalition, and I'm one of the TMaH doula consultants working with Maggie and her team on this aspect of TMaH. I have been a doula for the past 5.5 years here and have focused my work on serving underserved populations like mothers with substance use disorder, folks facing homelessness, and also working with immigrant new Mainers, very new Mainers. And so really excited to do this work with TMaH, and I'm going to hand it off to Sarah to introduce herself.
Hey everybody, my name is Sarah Toohey. I'm really happy to be here today with the TMaH team. I, like Kelly, was born and raised in Maine at Maine Medical Center, and I now live up on Mount Desert Island. So I have been a doula up here in Hancock County since 2012. So I work predominantly with people in Hancock, Washington, and also Penobscot counties. So I'm working with rural populations in my area. I think one thing about me as a doula that's a little bit different is I am a mentor trained doula. So I did a multi-year training with experienced doulas and also midwives to train to become a doula, which is, I feel like it was really valuable. It's a little bit of a different way that doulas are trained versus going through a kind of a standard training program. We're going to talk a little bit about what doulas are. Could I have the next slide? So a doula is a non-clinical and non-medical, and that's really important and in bold there. We are care workers who provide physical, emotional, educational, and I would even say logistic support through the entire perinatal period. So Some doulas are also providing spiritually or culturally congruent care with the people that they work with. In the rural areas, where oftentimes when people are traveling long distances to get to care, we're providing a sort of a connection back to people's home communities and a familiar person who's with them throughout pregnancy and birth and postpartum. Doulas, we're often kind of helping to aim people towards resources they need, social supports they may need, programs that may be beneficial to them. And then we're also helping people just navigate the healthcare system, try to figure out who they should be in touch with for populations like new Mainers who are not familiar with the US healthcare system. We're helping them understand the cadence of prenatal appointments and getting to appointments and the right people to talk to. And then presence of a doula also can sometimes help people's communication with their healthcare providers improve, help them understand what questions to ask, why certain tests are being done, and different things like that. Doulas are also sometimes referred to as birth workers. And we build really close and trusting relationships with the people that we work with. So we are embedded in the communities that we serve. Our clients typically have access to us 24 hours a day, 7 days a week via email and text and phone calls. So we are care workers who are really easily accessible to the perinatal population and the people that we're working with. And we're oftentimes, as somebody who's been a doula for over a decade, we are oftentimes working with families through multiple pregnancies. We know their older children. We know people over a period of years. So we really have a deep understanding of their values, their preferences, where they're coming from, their social determinants of health and different things like that can be really important for helping those people get the very, very best care. So doulas are an evidence-based way to improve perinatal outcomes. I could go through the very long list of improvements to both maternal health and also infant health. Most people know that the presence of a doula reduces C-section rates, reduces NICU admissions, reduces incidence of low birth weight babies and preterm birth, improves maternal mental health. So it's one intervention that really helps with a wide variety of outcomes. I do want to talk a little bit. We did the Maine Doula Coalition that I'm a co-director of. We did a workforce assessment that was published last year. And I think that's going to go into the chat. But one thing that I want to highlight, Kate's going to talk a little bit about traditional and cultural doulas. But one of the things that we learned from that workforce assessment was that the current doula workforce in Maine is over 90% white. 100% of our survey respondents indicated at that time, and this was last year, I know the landscape is changing, but indicated that English was their first language. In many cases, that was their only language. And the service map that we produced showed that there are very, very few doulas working east and north of Bangor. So rural perinatal populations don't have great access to doula services, and also our Black, Indigenous, people of color populations and new Mainers also don't have good access to doulas with shared lived experience. And so that's something going forward that we're really excited about changing in the state. I'm going to hand things over to Kate.
Thanks, Sarah. Yeah, I'm just going to say a little bit more about this piece about traditional and cultural doulas and doulas that serve really hard-hit populations in terms of disparities in outcomes. And so there are several newer initiatives that have been rolled out over the past year and a half, where there are small-scale efforts to educate, train, and support doulas from communities that are currently not really able to find peers within the doula workforce who share many important aspects of their background. And so we're seeing these small-scale projects really having positive outcomes for people, which is helping bring home how much we have to grow the doula workforce between now and the time that Maine Care can cover this service, but also telling us something about what kind of eligibility process we have to consider so that we can have the most inclusive sort of program, so that we can have a program that can really serve folks who are very hard hit, right? And, you know, Sarah just named a lot of those populations. And I would add to that, you know, from work on the femur panel, which I know some folks here also sit on, that we also have, you know, birthing folks with substance use disorder who are really having a hard time and are not necessarily getting that, I don't know what to call it, culturally relevant, really like experience to be able to support people. And so we're excited to work with folks throughout this implementation phase, pre-implementation phase, to ensure that we can provide Mainers with quality doula services where people actually have an option to work with a doula who shares some important aspect of their background and really can receive that culturally competent care. And we are seeing that it makes a really big difference for people. In my work with really newly arrived African asylum seekers, as a birth worker, I work in a team with a cultural doula who is African, and we team up together, and we're just seeing how much it helps to, what a difference doulas can make in people actually accessing healthcare, understanding their healthcare, experiencing more autonomy in their decision-making and having more informed decision-making. But also, just as Sarah said, we really help people navigate the healthcare system that is very new and confusing to a lot of people, particularly around pregnancy. Perinatal care is really culturally specific. So those are some of the things that we're just going into this considering. And I think the next slide we can move to, we'll say a little bit about our timeline for the doula piece. So you'll see the little star that says we are here. So we're at the very beginning. And Sarah and I have been working with Maggie and the whole team there. And one of our biggest sort of demands for this year is we're beginning to convene a statewide doula council. And so this will be an interdisciplinary team with lots of representatives from across the healthcare space, the community space. And this body is going to meet regularly to consider all the different best practices we've seen on the national level from other states that have implemented Medicaid coverage. We're going to look at what are the needs of Mainers and how can we really provide some guidance and some input on how this program is structured to best meet Mainers' needs. And so we are in that process. We're really excited to begin bringing that council together at the end of this year. Next year, we're going to be moving into rate determination. And then you'll see in 2027, we have to initiate that state level rulemaking. We have to seek appropriations. And then in 2028, that is when the services will begin being covered. And so, of course, the ongoing work is how we do education and outreach with the Maine care birthing population and also the workforce and providers who are going to make referrals and see doulas in those birthing spaces and those clinical spaces. So that's a bit of what our work looks like.
Thank you so much, Kate and Sarah. That was a wonderful overview. You're all done, right? Just a minute before I move to questions. Okay, we'll take any questions. There's been some resources shared in the chat. Any quick questions on the doula process? This one, again, is full. It has a really clear timeline and progression. So it's well established, well underway, and a wonderful team getting pulled together. Invites will go out soon to the Maine Care Statewide Doula Council. They will also be partial, a sense of those meetings or parts of those meetings will be public. So more to come if you want to just listen into that conversation some more. There will be a way to do that, and that will go out through public messaging. Next slide. So another big part of the TMaH model is implementing a value-based maternity services payment model under Medicaid. I love payment model. I know not everyone does, but we're going to spend a few minutes talking about what this means and more to come. Next slide. Just to level set, there are several different definitions of what is a value-based payment model, and there's 3 on the slide. I just actually decided I don't love any one of those more than the other, and I'm going to say it in a different way. MaineCare considers value-based payment models a way to pay for services in a way that directly incentivizes and rewards high quality and efficient care. The models that we offer in this way ideally offer flexibility in how care is delivered, so that providers and the people they are serving can actually reach the desired outcomes. And that flexibility is really in exchange for some level of accountability around actually achieving those outcomes. So it's a give and a take, but it's a way to move us away from a fee-for-service delivery system that oftentimes doesn't allow the most patient-centered and the most efficient care. Next slide. This isn't more background on, if you're not familiar with value-based payment models, they can range from something that is, as you go up the progression, just looking at performance-based payments, then you get a little bit more sophisticated with bundles of care or episodes of care, and then you get into full-on accountable care arrangements with shared risk and even capitated models. What's really important in talking about the TMaH payment model is that it is going to be a CMS, so federally determined payment model that the states then implement at the state level. So we have been working, and we'll talk about this with CMS throughout this process on giving our thoughts and suggestions, but later this year, we expect to have more detail on where on this spectrum CMS is landing for the TMaH payment model. So no specifics on what it actually is will be shared today. Next slide. CMS has shared and was part of the application that there is a transition period or a phased approach into implementing a payment model, a change in the payment model. So we're starting off year one, we're receiving technical assistance, we're helping to develop this payment model with CMS and their contractors. From a provider perspective, starting next year, Maine, as one state, hopes to start to push out what are called provider infrastructure payments in both 2026 and 2027 to help providers and care teams broadly prepare for transformations of care that will be necessary in order to be successful under a payment model. So these types of funds are still being articulated by CMS, but in a general sense are expected to be used for building patient safety initiatives, allowing teams to work on their data infrastructure for quality measure reporting, data integration, team-based care enhancements, connections to community-based organizations to address social and behavioral health needs. So a broad set of activities that, again, will hopefully lead to the development of infrastructure to be able to accept some level of accountability for outcomes. Then we get into model year 4, which is 2028, where we'll start to reward and track quality and cost performance among participating providers. And then we'll implement the full payment model thereafter. So much more detail to come for those who talk to me regularly about payment models in our Medicaid space. We'll have more conversation. There's not enough detail to get started right now, but we expect more detail coming soon. Next slide. So I already covered this, but basically we've been working with CMS and we may be reaching out to additional providers and stakeholders to provide additional input to CMS on this payment model design. We've at the state level have done a little bit already. So we've already in year 1 initiated a federally qualified health center maternal health services planning collaborative, which they've already begun to implement through the Maine Primary Care Association that will help FQHCs develop plans for how they intend to increase or change the way that they are part of the continuum for maternal health services, whether that's providing services directly or referring and helping develop those partnerships, which again may be very supportive of a future payment model. We are seeking vendor support for the rate model implementation and engagement because this gets into a lot of financial analysis, which we will work collaboratively on. And again, we're just sharing information with CMS. Next slide. All right, one more pause, and but it's gonna be quick. And those of you who work with me on payment models know how to find me for other conversations. Looks like we're good. Okay. So now we're transitioning into future TMaH work with our last 10 minutes. So this is the work of TMaH, again, either federally required or Maine elected, that we have not really started enough to have a speaker come and talk to you about it. That doesn't mean that work hasn't been moving on this front. So next slide. 2 other areas. So we really have an opportunity here to improve the data infrastructure to support maternal health quality of care. That will kick off with a data needs assessment that we'll be working with imagining CMS on the actual format of, and then engaging you all to determine where are the needs that need investment from a health IT perspective. We intend to also do some internal state level improvements in how we share data across programs to make sure that families can access the full amount of resources that they're eligible for during this time period. The next box is one where, again, work's underway. We just don't have, we're not going to highlight the specifics right now, but we're working towards this really exciting area. That's one of my areas I think is really, really beneficial to Maine, is that we're going to, under TMaH, be increasing the use of home monitoring services. Remote patient monitoring is another way to describe it, for gestational diabetes and hypertension. So Maine Care already has a very limited coverage of remote patient monitoring in different service areas, but this would expand that use to people who are pregnant, prenatal, postpartum, who are at risk for these conditions, and investing in how that technology gets rolled out statewide. So a lot of exciting work in that area, more to come at our next meeting. Next slide. There's 2 quality of care items which are critical, and Maine has been doing great work in this already. So the first, again, we are going to support the continued implementation of AIM patient safety bundles, which is currently work being done by the Perinatal Quality Collaborator for Maine, and they're here today, so they have resources in the chat, and you can connect with the team there. Maine's been doing great with this work. Some states weren't as far ahead as we were, so we're feeling good. We're going to continue to support this and additional patient safety bundles statewide. The other is another kind of more technical area where CMS has developed a birthing-friendly hospital designation in the prior administration at the federal level. And there's an expectation that states will continue to support their hospitals to meet that designation of standard of care. And Maine hospitals are doing great in this area. As standards change, we'll continue to make sure that Maine hospitals can meet the birthing-friendly hospital designation if in any way that we can help support them. Next. These last 3 are, we could talk about all of these for hours, but we wanted to make sure to highlight that community health workers play a role in many elements of maternal and infant health work. And so in a general statement, we are including and hope to include perinatal CHWs or community health workers doing perinatal support services throughout the elements of TMaH, and we'll be including community health workers in the planning process throughout this initiative. We also see great opportunity to expand group prenatal care. There's places in Maine that are doing this well, and there's lots of national models and evidence-based models to support this type of care delivery for this population. So we want to spread those good practices and create learning communities for other sites that may be well equipped to deliver group prenatal care. And lastly, big topic, but again, there's lots of opportunity to increase the use of telehealth and or mobile clinics or other types of alternative kind of ways to access care. And we intend to support, at least as one known, virtual behavioral health care for patients, because maternal mental health has been highlighted as a critical need for an area of need for where individuals are having trouble accessing the services they need in Maine. But there could be more under this initiative. Again, we expect that this area will grow over the 10 years. Next slide. So how to engage? Good question. Next slide gives you some ideas. And it's a lot of different ways that you could engage. And there's more. And you can throw those out in the chat. If you work at one of the organizations that you know you're working with us, you have other ways to engage. I mentioned PQC for me. If you have a way to engage, throw it in the chat. But some of the specific ways, you could participate in rural regional planning for your area. You could sign up for Maine Care e-messages, and we can put the chat in the link in the chat. That makes sure you at least get the public announcements about webinars like this and other activities. You can attend the Maine Care Doula Council meetings. If you're not a member, you can still attend and listen in. Many professional associations in this space have been forming their own committees or sharing information within their professional associations about this work because they want to stay engaged. So they could be a good resource for you. And if they're not aware of this work, like, we're happy to meet with your associations to make sure that they have the liaison with us to engage in this work at that level. You could work with your FQHCs on the Maternal Health Learning Collaborative. I mentioned PQZ for me. There's also the Maine CDC Maternal Health Task Force. So the Maine CDC does an enormous amount of maternal health work, and they have done for forever, for years. And they have a specific task force which regularly meets on a broader range of maternal health services, or maternal health issues, I should say. And you can join those meetings. And Jamie Paul's email is here. We put it in the chat. You reach out to Jamie, and you can just be part of that broader task force to addressing maternal health in Maine. When we get to the point of developing Medicaid rules and regulations, or even if you want to weigh in on some CMS policies, I heard some feedback on CMS policies prior in the chat. You should do that. Provide written comments to us or to the federal government, so we can take your feedback into account. And then lastly, like, we just love to hear from you. So reach out to Maggie, her emails on the next slide, and just let us know what we're missing and how we can build it in. We have 10 years, so we feel pretty good that we can build in things or find the connection to another resource that maybe can help you with your challenge or with your idea. So that would be our hope. All right. That was a lot, and we made it on time. So one more pause for any thing that people want to go back over or raise up. Awesome. Well, Maggie's critical email address here. She'll connect you to everyone else if you didn't catch their names. We're really excited about this. We know this is a group effort, and we want to make the most of these dollars. So please stay engaged. Thank you all for attending today, and we will talk to you soon.
Yes. Thank you all.